This is Brian Ormers recording a lecture for the second part of Cerebral Dysfunction, and we left off with near drowning. And so we're going to click here and hit the brief presentation for brief drowning on this one. In kids, this is a major issue because it is one of the major leading causes of accidental death. It occurs from asphyxia, so they don't get enough oxygen while submerged. They can drown even in a small amount of water. It just takes a couple of inches, quite honestly, for them to drown in, whether that's in a pool, whether that's a puddle, or such as in a pail of water. Toddlers are especially at risk because they tend to be top heavy. And so where I've seen lots of kids get into problems is that they put something in the bucket, they go in after it, but then they're so top heavy that they fall into the bucket, and then they can't get themselves out. Near drowning is defined as survived at least 24 hours after submersion, and that happens quite a bit. So some of the major things that happen during drowning is you get hypoxia, aspiration, and hypothermia. Think about the water temperature, and generally speaking, that's colder than your body temperature, so you get hypothermic from that. Aspiration can happen, but it's pretty rare. Most of the time you get a diver's reflex, and people will hold their breath and not usually drink a lot of water. If there's a lot of water in the lungs, that usually means there's a prolonged period of time after the patient has gone unconscious. Therapeutic management, of course, ABCs, airway, breathing, circulation, and starting that resuscitative efforts as soon as possible. Management is based on cerebral insult, which is really difficult to ascertain until after you see what kind of anoxic brain injury this patient's having. And that doesn't show up initially on any CTs or MRIs, and that usually takes, days to a week to show up. Prognosis, the best things is that it's a quick submersion. You get them back quickly with resuscitative efforts. It is in, this is non-icy water. I would say sometimes the cold water is actually beneficial for them because it shuts down their metabolism. And so I've seen some patients that were in icy water and do better because of it. Other things, as long as they've got a heart rate, that's always great. Reactive pupils, neural responsiveness at the scene. But you can imagine that longer time frames, no responses, is going to be a worse situation for that patient. So management really depends on what condition this patient is in. Do they need full ventilator support? Do they need lots of blood pressure support? Are we doing lots of coding? So care is really dependent on the condition of that child. The other thing we need to do is help out parents with coping with feelings of guilt. Oftentimes it's like, I just turned my back. I went inside to grab a glass of water when I was out at the pool, and they have a lot of feelings of guilt and a lot of anxiety related to how their child's going to do that. Best thing we can ever do, of course, is prevention. So, look around the home, look for areas where they can drown in. Do not leave your child alone in a bathtub. Do not leave your child alone in a pool. Do not leave, puddles of water or buckets of water sitting around. Those can all be very dangerous things for kids. All right, the next thing we're going to talk about is brain tumors. And this is the most common solid tumors of childhood. So they make up about 20% of childhood cancers. And really, they vary depending on where they're at, how big they are, and what things that they're pressing on. So some of the major clinical signs you might see would be headaches, nausea, vomiting, poor eating, lack of balance, double vision. Some of the ways that we look for this and try and diagnose it, first we'll do like a CT or an MRI, and then we might do an LP. We talked about this with high pressures before, and how if you do an LP and they have a high ICP, you can cause herniation by relieving that pressure down below, which causes the brain and the CSF fluid up above to rush down. Other things we can do would be, trying to get a biopsy through surgery, and then sending that into histology and getting a definitive tissue sample on this. So treatment varies. I'm not going to get into particular types of treatments for particular types of brain tumors. whether it's an astrocytoma or whether it's something else. It all varies a little bit. The other thing that really varies your treatment is where it's at. Is it at a place where you can do a surgical correction on this or not? If it's deep within the brain, you don't want to go through a lot of brain tissues to try and get this tissue out, and radiation is probably your better bet. If it's something superficial and you can cut it out and excise it and get good demarcation with that, then that might be your best bet. Chemotherapy is not used extensively because we have a hard time getting it to cross that blood-brain barrier. We can do things such as interthecal, so it's like the opposite of an LP. So we put the spinal needle in and we inject instead of withdraw. But giving it in a traditional route through a port and then having it go into the blood doesn't usually cross that blood-brain barrier very effectively. And we've got two barriers in the body, at least guys do. So, of course, there's the blood-brain barrier, but then there's also a barrier in guys down into the testes. And that's why it's very important for any kind of a cancer diagnosis with males that you're doing a testicular exam. Other things we can see, intracranial infections. So we're talking about meningitis or encephalitis with this one. And so oftentimes we're just seeing the signs and symptoms of it. To be definitive, we have to do an LP to figure out what kind of causative agent this is. It could be viral, it could be bacterial. If it's bacterial, they tend to be a little bit worse, but we have antibiotics then that could subsequently treat them. Viral tends not to be as bad. However, it's harder to treat. We do have some antiviral drugs. Such as a cyclovir that we can use against HSV, which is herpes simplex virus. There can be pest-related things, such as West Nile, which gets carried by mosquitoes, or you can have other tick-borne illnesses. You can have rabies. And rabies is often the highest in children because they don't have that common sense yet. They go out running, petting the black and white kitty, not realizing that it's a skunk that might have rabies. Bacterial, though, one important thing is look at the vaccine preventable ones. And so we've come a long ways with that one. And as our vaccines get better and better, we're seeing less of some of these, such as Hib and strep pneumonia. So that's really getting better with that. So what do the patients look like? Well, it kind of depends on what's all presenting, but once again, it's just like any increase in your cranial pressure. They're going to have a headache. They're going to have some photophobia. They're going to have altered mobility, probably not eating very well, crabby, irritable, photophobia. So all those things might be clinical diagnostics. Therapeutic management, so of course we want to hydrate them because if they don't feel like eating, we don't want them to get dehydrated. We want to promote circulation, especially if they go into a shock like a Neisseria meningitidis that we talked about last time. We want to maintain good ventilation with them. This might actually even mean ventilator support. Control any seizures that they might have. Limit their temps if they're running fevers. And then, of course, ICP monitoring, where we take a bolt, which is a pressure monitoring device, and put it in through the skull and into the ventricles and monitor it that way. We're going to do good isolation because guess what? Nobody else wants this, including you and your family and your friends and other patients that you're caring for. If it's bacterial, like I said, antimicrobial. If it's viral, acyclovir might help. Vaccinations, of course, is going to help, hopefully before they get this. But if they're exposed to rabies, then, given the passive immunization, so it tries to prevent full-blown rabies. And then, of course, close follow-up care and reevaluation. In little kids, it's hard to sometimes tell the knowledge or the deficit that they might have because kids don't do a whole lot yet. So it's kind of a delayed presentation with that. Rye syndrome. Rye syndrome I'm going to breeze over because we don't see it a ton. But the one thing I want you to do is make sure you make this association that we do not give aspirin to febrile children because there is a link for this. to Reye's syndrome. About the only time that we ever give aspirin in kids is for, as you guessed, Kawasaki's disease. And because we're trying to prevent giant aneurysms of the cardiac and the coronary arteries. But that's one of the few times we ever give aspirin, and that is why it's related to this. So seizures, there's lots of different presentations for seizures. There's some good examples of what these look like. So absence seizures, oftentimes these kids are getting in trouble in school for daydreaming, not paying attention, and in reality they're having a seizure. Atonic seizures or drop seizures is when they lose all muscle control and they tend to fall over. And when they fall, they tend to fall pretty straight and usually hit with their head, unfortunately. So remember that seizures can really be everything. The way that they can present is either slight muscle twitches or grand mal seizures. It's really varied on the presentation of seizures. Hydrocephalus is an abnormality in which we have too much CSF fluid. It might be early onset, so apparent in early infancy, otherwise it could be of later cause. But basically, you're making the CSF fluid, but you're not able to get rid of it. So treatment that we'll do is called the VP shunt. It's ventriculoperitoneal shunt, so going from the ventricle and draining it down and into the belly. So, sounds all well and good, but shunts can get infected, and patients do get very sick when they get a shunt infection. Shunts can fail. I've seen shunts have too much protein in their CSF fluid, and it clogs it off. And then, of course, kids can outgrow them. So if you look in the previous slide, if that tubing isn't long enough to grow with the patient, it eventually pulls out and comes out of that peritoneal space. And so then they need a surgery to replace that and make sure that there's long enough tubing to go from that ventricular space into the peritoneal space. So the one thing I want you to do now is to complete this case study involving VP shunts, and then we will review it later. That concludes this lecture. If you have any questions over it, please contact me, and we'll go from there.